who would be talking to us on current clinical practice of hypothermic machine perfusion in kidney transplantation. One announcement, please. From 6:45 p.m. onwards, a van will be leaving from here, dropping delegates at the dinner venue, namely Jenny's Club. Thank you.
So, good evening, everybody. So, welcome to the last session of today. It's on current clinical practice of hypothermic machine perfusion in kidney transplant. Already we are running quite late in time. I request the speaker to deliver his talk.
Sure, sir. Good evening, everyone. Thank you for the wonderful opportunity. We'll be discussing the current clinical practices of hypothermic machine perfusions. So I'll be discussing the topic under these 8 major headings: static cold storage and how the cold can injure the kidney, and the commercially available machine perfusions in India. One is HMP, which is called Lifeport, and one is oxygenator HMP under the name of Hope, and the brand name is Vitasmart. And we'll see the protective mechanism of these hypothermic machine perfusions, both the oxygenated one and unoxygenated one. And we'll see the clinical evidence how these hypothermic machine perfusions are better than the routine static cold storage. And we'll compare the oxygenated Hope machine and the Lifeport, and we can see which one is better when compared. And most interesting topic is we can use this HMP as a graft viability assessment tool. We'll see that too, and we'll see the timing of HMP, and finally our experience in the machine perfusions. So all of you know the first one is the Lifeport portable machine perfusion system, and second one is the Hope, which carries an external oxygenator, which delivers very high concentration oxygen in the perfusion fluids along with the other nutrients. So the slide shows the temperature differences in different techniques. In static cold storage, the temperature is usually 0 to 4 degrees, and in this hypothermic machine perfusions, the temperature is between 4 to 8 degrees. And there are two other machine perfusion systems. One is normothermic machine perfusion system, and second is subnormothermic machine perfusion system. The temperatures in NMP is between 35 and 38, and SNMP it's 20 to 34. Both these machines are under studies, and currently there is no commercially available machine in India. So I'll restrict my discussion only to this hypothermic machine perfusion system. So as all of you know, we all use this standard cold storage as a routine method. It's the simplest method and most commonly used for both organ storage and organ transport. And the hypothermia, as we know, slows down the metabolism. For each 10 degrees in temperature, the metabolism goes down by 2 or 3 times. So in the normal static cold storage at 4 degrees, the only 5% of metabolism continues, but still in a longer run, this prolonged cold ischemia time can affect the cell viability and can cause cell necrosis. So we all know this prolonged cold ischemia time is an independent risk factor for DGF and sometimes primary non-function. And for every 6 hours of cold ischemia time, the DGF increases by 23%. We all know DGF in turn provokes rejection. And compared to the DBD kidneys, extended criteria donors and DCD kidneys are more vulnerable to cold injury, and they are more susceptible to get DGF and primary non-function. So here comes the role of machine perfusion, which can preserve the graft from DGF and in fact reverse the injury caused by the static cold. To understand the protective mechanism of the hypothermic machine perfusions, we need to understand the basis of ischemia reperfusion injury. The slide explains the basic mechanism of IRI. In normal status, the nutrients and oxygen is delivered. The cell is in aerobic metabolism mode. Mitochondrial electron transport chain is active, and the ATP is generated in abundance. During the initial warm ischemia time, the tissues divide of both the nutrients and oxygen. The cell switches to an anaerobic respiration mode. ATP is depleted, cellular lactic acid it builds, and the reactive oxygen species are generated. And when the cold ischemia storage happens, this entire process is slowed down, but it never ceases, and the cell continues to damage, but at a slower rate. So finally, when the organs are reperfused, the oxygen comes back, it brings back the cell to an aerobic respiration mode. ATP starts recovering, but along with that, this RO system, the reactive oxygen species, they're all generated and they continue to injure the kidney. So basically, the ischemic injury, cell injury is by anaerobic metabolism and by building up the lactic acid inside the cell, and the reperfusion injuries by the reactive oxygen species. And the reactive oxygen species, they damage the endothelial like glycocalyx, and is also damage the endothelium, which in itself turns into activates the platelet aggregation and platelet activation. So also the endothelial damage increase the leukocyte adhesions and leukocyte migration, and the whole circle of inflammation starts. So the reperfusion injury is rightly called as sterile inflammation. So machine perfusion, we'll see how it protects the graft from the cold injury. So these are the following mechanisms. Just by the virtue of constant flow and shear stress in the vasculature, machines can protect the endothelium. It increases the nitric oxide and it prevents vasospasm. It also clears the debris, free radicals, and metabolites from the tissue. Secondly, anoxia causes anaerobic metabolism. The oxygen delivered by the HOPE machines, they sustain the aerobic metabolism and maintain the ATP levels and prevent cell death. So there's a specific concept called cold oxygen. So in a supraphysiological oxygens delivered at hypothermia, they have a specific protection effects. One, it reduces the ROS system. The oxygen free radical production is reduced in mitochondria during reperfusion. And second, it protects it from the endothelial damage. It also reduces T cell stimulation and macrophage activation. And finally, something called DAP, it's a damage associated molecular proteins. These are generated during injury, and machine perfusion, they reduce the generation of the damp molecules. So let's see that this is the physiology. Let's see the clinical evidence which supports machine perfusion compared to the static cold storage. The first study is from Netherlands, the country which uses machine perfusion as a standard of care. So they found that HMP reduces the DGF compared to static cold storage, and the effect is more pronounced in DCD kidneys compared to the DBD kidneys. And so these are the values. In static cold storage, the DGF percentage was 43.7%. It was only 38 to 38.2% in machine perfusion. And also the duration of DGF was significantly lower in machine perfusion. It was only 7 days compared to 9 days in static cold storage. So this protective mechanism is enhanced in DCD kidneys compared to the DBD kidneys, as we can see from the p-values. But although the DGF rates are lower, and DGF duration is lower, the 1 year and second year graft outcome in terms of creatinine, EGFR rejection, and the graft failure are similar between both the groups. So this is the first study, but there are two other meta-analyses which say otherwise. They found that they also found the HMP reduces DGF, but it also increases 1 year graft survival. So we have two studies. The first study is from 2013 study, and the one marked in red is hypothermic machine perfusion studies, and second one is cold storage. The DGF rates is obviously less in all studies. There are some randomized control studies, there are some non-randomized control studies, there are small group study, there are large group study. So every study tells us that DGF rates are less in machine perfusion compared to the static cold storage. So this meta-analysis compared the primary non-function rate. But unfortunately, some studies showed protective effect by HMP and some studies doesn't. So 1 year graft survival was better with hypothermic machine perfusion, but the patient survival was not. So, this point is like reinforced by the another meta-analysis, which is the 2016 study, and they also found HMP reduces DGF, but HMP increases 1 year graft survival, and in fact they found HMP reduces the primary non-function rates. And we can see the DGF rates are less with HMP, the primary non-function rates are less with HMP, and the 1 year graft loss is more with the static cold storage compared to HMP. So, there's one more recent study which showed HMP reduces DGF, it increases 1 year graft survival like the previous study, but it also says that it increases 3 year graft survival compared to static cold storage. This is the forest plot shows lesser DGF rates and lesser graft lays with HMP and lesser 3 year graft loss with HMP. All these were more in the static cold storage. So this is one 2012 study from NEGM, and they also proved that machine perfusion is better than cold storage, and the 3 year survival of kidneys with machine perfusion is better than cold storage. And basically they had 4 categories: machine perfusion without DGF, machine perfusion with DGF, cold perfusion without DGF, and cold perfusion with DGF. and the best outcomes were with machine perfused non-DGF kidneys, and the worst outcomes were with cold storage with DGF. So how does the HMP improve this long-term outcome, the 3-year graft survival? So this is possible by an explanation. So there are the graft IFTA depends on two major factors. One is this epithelial to mesenchymal transition, and second is a production of hypoxic inducible factor HIF1A. Both these things were reduced by HMP. So in that way, HMP prevents an long-term IFTA and improves the graft survival. So the same study figured out the rejection rates were lesser with HMP, and these are the molecular mechanisms. One, it reduces the DAMP, as I already told. DAMPs are the proteins which initiates the inflammation. And second, it reduces cytokine level in the kidneys. And third, it directly inhibits the donor immune cells. So by these ways, HMP can reduce the rejection rates. In fact, there were two small studies. One from Tosi et al. They figured out the inflammatory cytokine levels were lower with HMP kidneys, and even there's one more study which is Resnick et al. They found lower number of rejections with HMP kidneys, but these were small studies with small numbers and should be interpreted with caution. So now we know compared to the cold storage, HMP has a better outcome. It has lesser DGF and better long-term survival. But out of the two machines, which one is better? So the answer comes from the most recent trial. This is published in Lancet in 2022, and it was done by the COPE Consortium of Organ Preservation in Europe, and it compares the non-oxygenated HMP with oxygenated HMP. This is the first and the only RCT available until date. It's an international randomized double-blind paired control phase 3 trial, which happened it included 12 organ procurement centers and 19 organ implantation centers conducted over Belgium, Netherlands, and south of UK. And they chose the DCD kidneys, which were more than 50, from the donors who were more than 50 years of age. So basically, the donor demographics were similar between HOPE and the non-oxygenated HMP. So regarding the age, sex, and body mass index, and cause of death, both were similar. And regarding the recipient demographics, all were similar: age, sex. In fact, the HLA mismatches, PRA antibody percentage, and the immunosuppressive measures were all similar between both the groups. And the primary outcome was EGFR at the end of 1 year, and the EGFR was measured by CKD EPI formula. So the EGFR was numerically better in HOPE group compared to the HMP. It was 50.5 with HOPE and 46 with HMP, but this is not statistically significant, only numerically better. And similarly, creatinine clearance at the end of 1 year was numerically better with the HOPE kidneys, but not statistically significant. But the most important point is that HOPE kidneys, they had a lesser acute biopsy-proven acute rejection rates. This was one major finding. And also, the graft failure rates were lesser with HOPE machines. It was 3% in HOPE and 10% in the non-oxygenated machine perfusion. And more importantly, whatever the graft failure happened with the HOPE, it happened within 3 months, and there were no graft failures after 3 months. But in the HMP group, they had more graft failures at the end of 1 year, and they continue to have graft failure even after 3 months. So the superiority of the HOPE is well studied and proven in liver transplants, but this is the first and the only study available until now, which proves that HOPE has a better GFR, and it gives a lesser rejection rates. So how to use a machine perfusion as a graft viability assessment tool? So in cold storage, there is no way of assessing the graft function. So we often do biopsies and do frozen section, but that tells us the morphology, but not the functionality. So, but the machine perfusion can be used to predict the viability of the graft. We can assess the viability in 3 ways. First is the perfusion flow parameters, and second is measuring the biomarkers in the perfusate, and third one is MRI. And both the MRI testing and the biomarkers are in experimental stage, but the flow parameters are very, very well studied and can be used clinically to predict the graft outcome. So both the LifePort and the HOPE machine have these monitors. There are 4 major parameters. The first one is the pressure, which is set in the machine. The 29 here and 25 here, they are the machine pressures we set. Usually it's set between 25 to 30 millimeter of mercury, and it's always kept constant. And second is the actual pressure delivered inside the kidney, 24 here and 26 here. They are the actual pressures inside the kidney. And third one is the flow or flex, that's 36 ml per minute here and 48 ml per minute. And that's the actual flow delivered. And last and most important thing is the resistance we measure. It's 0.72, the 0.54. These two values are the resistance. And the resistance is basically the pressure divided by the flow rates, and the unit is a millimeter of mercury per ml per minute. So in the recent study, this is a 2022 study, these three parameters, that's flex, pressure and resistance, they were measured both at the initiation of the machine perfusion and at the end of machine perfusion. And those kidneys which have a significant parenchymal injury and going for DGF, they will have a more parenchymal resistance and hence more pressure and less flow. And similarly, the kidneys with lesser injury, they have less resistance, so more flow and less pressures. So generally, the chance of DGF is less when the flow is more than 150 ml per minute in the machine, and the delivered pressures are less than 30 millimeter of mercury. In fact, the study found out of all the parameters, the terminal resistance is the best parameter to predict the outcome of the kidney. Whether the kidney will go for DGF or not, the terminal resistance can tell us. So those grafts with terminal resistance less than 0.19 millimeter of mercury per ml per minute, they had a lesser chance of DGF, and those kidneys with more than 0.19 millimeter of mercury had higher chance of DGF. In fact, we also can predict the primary non-function through these parameters. So those grafts with high initial resistance, and if the value remains more than 1 millimeter of mercury, even after 3 hours of machine perfusion, so those kidneys are more likely to go for a primary non-function, and they need not be even transplanted. So coming to the biomarkers, these are list of biomarkers mentioned. Out of them, only 5 are very important. The glutathione GST, glutathione S transferase, LDH, lactate, fatty acid binding protein NGAL, these were better studied and correlated clinically with the incidence of DGF. But out of all these things, only GST, which is glutathione S transferase, was well studied. Both the alpha GST and total GST values, they had a reasonably good positive and negative predictive value. But the downside of the biomarker is that it cannot predict a primary non-function. And until now, there is no standard, the time of sample collection, no lab values to correlate clinically. So, and final one is a MRI spectroscopy, but it's still being researched as a potential objective method to assess the graft function. So they used a MRI compatible machine perfusion system, and this technique used water molecules as endogenous contrast agent, and they used this special software, the atrial spin labeling, which gives us the signal intensity at the cortex. The first image, it's from the porcine kidney, and this is from the actual human kidney. And the signal intensity is produced, they give us an idea about the cortical perfusion. So as I already told, this is still under evaluation and could be a potential tool in the future. So coming to the timing of machine perfusion, when to start at the machine perfusion. So we all get the cadaver alerts, and retrieval times are highly unpredictable, and not every time we have the organs can go direct to the machine without even directly after retrieval. So plus HOPE machines are usually not portable to the place of organ retrieval. So is it okay to keep the kidneys in ice for a certain period of time before implanting? So the answer comes from this study. So they chose the marginal kidneys. It included ECDs, uncontrolled and controlled DCDs. Basically, the in-house kidneys stayed in the ice for an hour, and in the HMP machine for close to 14.5 hours. And the kidneys imported from different centers, they remained in cold for 10 hours, and then they were placed in HMP for another 7 hours. So despite the significant difference in the cold ischemia time, HMP still was found to be useful. And so this says that the DGF rates, acute rejection, graft survival at 1 year, and patient survival, creatinine clearance, all were similar between those kidneys which remained for 1 hour in cold and 6 hours in cold. And this long-term HMP did protect the kidneys well. So encouraged with this result, they studied this effect of end cold ischemia time, which is pre-implantation HMP, which is called the COPE-POM trial. POM signifies pre-implantation oxygenated machine perfusion. So in this trial, the kidneys were either implanted straight from the cold, or the HMP was used for two hours before implantation, And unfortunately, it's a negative study. The survival, graft survival or the creatinine clearance, primary non-function, DGF were insignificant. So the 2 hours of hope was not beneficial. Only the long-term hope was beneficial. So coming to the our center experience with Lifeport and Hope, in the past 1.5 years, it's a small group only. In the past 1.5 years, we have utilized machine perfusion only for extended criteria donors and those marginal donors. So for all our DBD kidneys, they were utilized after static cold storage. Only we utilized machine perfusion for ECDs and marginal donors. For 10 transplants we have done the past 1.5 years, and out of them 10, 7 were ECD kidneys and 3 were marginal donors with high creatinine. Creatinine varied between 2 to 5.9, and four times we used Hope and 6 times we used Lifeport, and the cold storage varied between 45 minutes for in-house kidneys and 9 hours if it's an imported kidney. And the HMP time was 2 hours, minimum to 5, maximum 5 hours. Fortunately, until now, very small study, observation, we never had a DGF, we never had acute rejection. The native creatinine was below 1.3, and 1 year graft survival was 100%, and 3 of the kidneys across 6 months, and they are really doing well. So just to mention one interesting patient, we had a 30-year-old donor without any comorbidities, and he was in hypotension. The creatinine was creeping for 2 days prior to donation. Unfortunately, he had a cardiac arrest. A brief CPR was done for 10 minutes and revived, but BP dropped and the urine output dropped post CPR. Allocation and retrieval was done 4 hours after the CPR. So we did a frozen section, and then it showed a severe ATN, but no glomerular sclerosis and only IFTAT less than 10%. So this kidney spent 6 hours in the eyes and 5 hours in Hope machine. So these are the initial flow parameters. As we can see, the pressure was 20, set as 25, but it was 26, and flow was initially less, only 48 mLs per minute, and the pressure initial resistance was 0.54. But fortunately, 45 minutes into the perfusion system, the pressure dropped to 22, and in fact, the flow became 250 from close to 50, and the resistance dropped to 0.09. And so the kidney was implanted on a 32-year male who was on waiting list for 3 years, and urine output was decent. There was no DGF. He never required dialysis, and the creatinine dropped down to 1.2 on the day 10. So the made kidney, it was implanted after 3 hours of cold storage. It unfortunately it had a DGF requiring 3 sessions of hemodialysis before recovering. It took nearly 2 weeks to recover. I'm not sure whether Hope prevented the DGF, but for sure, to start with, this is a marginal kidney with the AKI. On top of that, the patient had a cardiac arrest and had a warm ischemia time, very significant. We were in dilemma whether to go ahead or not, but the pump parameters, initially it was high, but within 45 minutes, the pump parameters fell, so it gave us a clear idea that the kidney can function and we can confidently go ahead. So, and to conclude, static cold storage just slows down the injury, but the cold eventually harms the kidney. HMP can preserve the graft. Reperfusion injury after cold storage is high compared to reperfusion injury after machine perfusion. And HMP does this effect by reducing the ROS. And the DGF rates were high with prolonged cold storage, and DGF rate were reduced within machine perfusion. And in fact, it gives better 1 year and 3 year graft survival compared to cold storage. So also the HMP can be used as a graft assessment tool, and so the standard of care for ECDs, at least for ECDs and DCDs, machine perfusion should be the standard of care, and we can always use statics to cold storage for live and DVD kidneys. So regarding the comparison between Hope and the other machine, there is an edge for Hope, as we saw from this new Lancet study, where Hope give better GFR and lesser rejection rates for the kidneys. Thank you.
Thank you, Dr. Prabhu, especially for filling in for the original speaker at the last moment and delivering the lecture. Thanks a lot. You use this HMP for all this one, or only for cadavers with marginal, this one you're using, or all the cadavers you're using?
For DBD kidneys, only were used for ECD kidneys and marginal kidneys. The routine DBD kidneys, they remain in static cold storage.
And when the needle is placed inside, you are going to clamp the arteries around the the cannula? Yes, sir. The Hope has a cannula, and then the Lifeport has a complex mechanism. It's not a cannula. It's like a closing system. There are two parts which will close around the artery and the vein. I think If everybody agrees, not many of us would have used it. So a small video would have helped us as to how the procedure is done. Any questions are there?
The Cochrane review on this is very clear. Basically, they have taken up all the meta-analysis and they have done a Cochrane review. So for SCD kidneys, there is no advantage. For ECD and for the DCD, there is a sure advantage. So having trained in roughly around 300 plus transplants, the renal transplants on this system, the LifePort, during our AST training many years back. So the advantage what it gave us were there in North America and Canada, every kidney was on the LifePort. We used to go harvest and put them on the LifePort. The advantage was the operation theaters were all doing the elective ORs. Correct. It was never an urgency. We used to put them on the LifePort, give them, hand over to the OR manager. At the end of the day, we used to do the surgery without much of any DGF. So that was a confidence on which we had. And it was also helping us to test whether this kidney has a DGF or not in the context of assessing the dynamic parameters, like the perfusion pressures, the resistance, what we are seeing. The moment we found a little bit more resistance in the perfusion pressure, that's the kidney which will go next hour into the OR. Otherwise, the daily schedule of the surgeries were never, disturbed. That's the confidence we had. But again, having said that, the caveat was it's an expensive system, not for all, not necessary for all. SCD kidneys can be managed by the cold storage static. And ECD marginal kidneys, yes, it's a go. Thanks for that.
Thank you.
Dr. Saravanan, is there any possibility for this to be utilized in live donor utility?
Sir, actually, live donation, the ischemia time is very short, only 30 to 40 minutes. I don't think it's needed.
Because 18 also
but there
happens,
was one, sorry?
Because 18 also happens in because of the warm ischemia time.
There is a small study, they have used a live port for live transplantation, especially for swap kidneys, where the organ goes from one center to other. And they have found that there was no, the 18 rates, biopsy 18 rates were lesser with live port and HOPE machines compared to static cold storage. There was a definitely advantage. It can be done, but the cost might be a restricting factor. Putting a kidney into the HOPE machine or live port will definitely cost few thousands.
Whether the vessel tip that we usually use for this cannulations of this renal artery, that is 2 mm, 3 mm, that is what we usually use for live transplants. But if you take up the cadaver, it can be a larger cannula. Yesterday they had got the mission to the day before yesterday. They had got this mission to the pre-conference interventional nephrology workshop that we conducted. And they were able to have a cannula that is a bit large enough. So if it is going to be a cadaveric transplant, if we are going to get it with an aortic patch with the renal artery, I think that size will be adequate for its usage in deceased donor. But I'm not sure whether they have also this 2 mm, 3 mm possibilities of cannulas to be used in live transplant settings.
We had issues actually. Live port, if it's a double artery, even in diseased donor transplantation, it's kind of tricky. You can't use. There were not many cannulas which can be used for a double artery. So,
how is that ensuring the if you put a cannula and put a clip, whether will it not leak out? Because
no, there's definitely not a leak. I mean, if there's a leak, this machine is not going to work. And the live port, it's not actually a cannula; it's a closing system. I should have brought the pictures.
We needed a small video on how it works.
I missed it actually.
thank you.
So my question is also like similar. Can we use this for the standard criteria DBD with prolonged cold ischemic time? Whenever we expect a prolonged cold ischemic time, can we use this? And the second is like, what is the perfusion fluid we use in this? What is the cost of the machine and cost of this procedure, if at all we want to use? So what will be the cost of the, the consumables and everything? Yeah. And how long we can use this? How long we can maintain in a hypothermic machine perfusion?
The first question was like, can we use it in DBDs, routine cadaver transplant? Definitely we can use. There are multiple studies which it definitely reduces. If it can reduce DGF rates in DCD kidneys, it also reduces DGF rates in DBD kidneys. This first Netherlands study, it showed that the effect was better in DCD kidneys, but obviously even for DBD kidneys, it does reduce the DGF rates. It can be definitely used.
And the cost, what would the cost?
Cost, I don't, For each patient, they used to charge differently. For initially for 10 patients, some of them they never charged. Some the charge for consumables, it came somewhere between 75,000, somewhere around 25,000 was the overall cost. And regarding the time we can use for HMP, it can be the maximum hours we have used 9 hours. So basically, we stop when everything is ready. Patient is ready, when recipient is ready, when cross matches are back, we can straight away go for the transplantation. The maximum, there are studies which had close to 7 to 9 hours of HMP usage. So we can
And
use
what
it.
would be the cost
And
of
there
the
are even
machine?
small studies where they cross 24 hours and then the kidney still functions well.
Okay. You know, if you want to have that, what could be the cost of the machine?
Machine, I'm not sure.
Okay.
Not trying to answer.
Just adding to that, in a live-related transplant or live transplant, it is just we take 5-10 seconds to insert the cannula and start the perfusion.
Yes.
How much time does it take to set this up and put the cannula, clamp it, and then start the process?
Not much, sir. Actually, when you ready the machine before getting the kidney out, and it hardly takes few minutes to just the artery and venous cannulas. It doesn't take more than few minutes.
The life port, it is easier to cannulate a deceased donor because you're going to take the kidney with the Carroll's patch. So it's easy to clamp it because it's got a clamping system in the life port. Whereas in case of the living donor, you don't take a Carroll's patch. So it's pretty much difficult, almost impossible to clamp in the life port. Now, having said that, I mean, with regard to the living donation, we are doing a lot of paid kidney exchanges. So at least even in India right now, what we do is that we want both the pairs to come to the same hospital and then we do it at the same time anesthetized. But that's not a thing in the West because that's the confidence they have on a standard criteria kidney that the kidneys actually fly from East Coast to West Coast. The donors never fly because they don't get reimbursed for the loss of employment and the leave, and they like to be in their own places. Actually, the kidneys are flown in the regular commercial flights. So 8 hours, 7 hours, outcomes are not bad. A little bit of creatinine, slow clearance, TAC, you can manipulate a little bit, but otherwise, SCD kidneys, they resist ischemia pretty well.
No more questions. Thank you once again. We'll close the session for today. Thank you.
Thank you, sir. May I request the chairperson to kindly honor the speaker, Dr. Prabhu, and Dr. Muruganandan to honor the chairperson.